I'm Chalovit Jalali from Thailand. Today my topic is arthroscopic LCL reconstruction in elbow. This is my hometown, this is my country, Thailand, right? We have a land of smile and have a list of the food, list of the culture, list of the beautiful fish. My hospital is Singapore University. The name is Mahachakti Singapore Medical Center. We take care about the people stay on the north of the Bangkok until the province that extend from the northeast of Thailand until to border of Cambodia. I still work in some brand name of the hospital, private hospital. I make work with the Singapore Singapore Hospital that have the many expat patients from UK, Europe, America, Japan, and also Southeast Asia, like a CLB patient. So around the world can come to take care about the orthopedic problem over here. We also know that instability means the failure to function under physiologic load. Symptoms may be can form like a pain until the feeling of loose of the elbow. Sometimes with patients with the catching, locking, snap, and clunking even in the loosening of the elbow. Classify of instability rely on many aspects. That if you classify along the direction, you can classify like a one direction, such as a posterolateral instability or medial instability, or until the global instability in the elbow like a medial and lateral instability. Sometimes we can classify like a clinical sign. Sometimes it does only have the functional instability that can present only with the pain. But the pain will relate with the push-up activity or relate with the chair-rise activity that quite the character of the instability pain. Some patients present with the laxity, so we can examination to show something like a laxity sign positive, such as like a posterolateral downward chest, or maybe like a power chip chest positive, even awakening, as in this patient. For the cause of instability, it can come from automatic, such as like a chronic repetitive use, such as like a baseball player, racket player, like a tennis or badminton, or even the chronic user like crutches or wheelchair. And many times we found the patient that have the repetitive injury from the steroid injection. We also include them like a traumatic cause. And for the traumatic cause, surely we will have a history of injury, such as this patient. Our stress injury and have the suddenly damage of the ligament around the elbow and have the elbow dislocation. Common scenario of elbow instability, we have from the experience, we have a T scenario that one is an automatic cause that can come from like a posterolateral rotatory instability until global instability. And automatic cause such as like steroid-induced semicircle and chronic adhesion, such as like chronic varus deformity, touch dependent, wheelchair dependent, or heterogenic. Another issue is a medial instability that quite not common to found in our country, especially in Thailand. But the country that have the baseball player may be quite common. So in this today we don't have this topic in there. For the traumatic instability, we also know the pathology that can happen damage from the lateral to the medial sides as presented by the poly that we call a poly circle. The problem is like a sequelae of the dislocation. So acute management should be proper. Sometimes it's too wrong immobilized, you will get a stick. And if you undetect and neglect it and make the patient not have the proper treatment, maybe you will have the sequence like an instability later on. especially for the posterolateral rotatory instability. In the case of automatic instability, automatic instability we can cause by steroid abuse. You have a many-time steroid injection, especially that you have a diagnosis that tennis elbow and you use a steroid like a routine. That chronic addiction like a chronic villus deformity, crush dependent, wheelchair dependent, and also hypertrophy. In 2001, Professor Charles Hall presented how the posterolateral rotatory instability was introduced by him and his school. They found that in the case of chronic villus angulation more than 20 degrees, in the normal activity of daily life, such as the push up from the chair, push from the chair or chair rise, they also have some cause of abnormal force on the LCL. So it makes the LCL attenuation in the long term. So it can cause an instability in size. Example, like this lady, 40 years old, female, have a history of elbow injury 20 plus years before. Right now, she comes with the pain and also have a clumping in her elbow. She have a villus deformity, quite big ankle in there. And you can see that she also have a pivot chip application, pivot chip positive group. For the tennis elbow, lateral epicondylitis. Lateral epicondylitis, like a tennis elbow, is like a cell-limited disease. Still need the treatment. Over-treatment like a steroid abuse can happen in there. In my series that we take care and survey in depth, we found that for the chronic lateral elbow pain that need arthroscopic surgery, only 17% have a pure tennis elbow. And we found that hidden instability found up to 20%. And our series, we not found any radial tunnel syndrome. That in the literature more or less said that radial tunnel syndrome we found in the tennis elbow surgery about 15%, but we not found in our patient. And they have many literature to find out that in posterolateral rotatory instability, most of the time that come from the automatic event is related with steroid abuse. We also have that experience too, that have a steroid abuse from the liver case that we used to treat. How about the treatment of elbow instability? You have a two choice, conservative treatment and surgery. Surely, conservative treatment, the success rate is quite low because daily life activity prone to make an instability. It's quite hard to avoid the instability of the elbow, especially in posterolateral rotatory instability. For the surgery, lateral ulnar collateral ligament reconstruction still be the gold standard in there. Again, this male 35 years old present with the lateral elbow pain and clunking sound on his elbow. History of elbow dislocation and reduced in the local hospital. They present with the pain and have this side of the instability. This is a posteral downward test. It's like that. We can make a downward test. It's like a gate tube. And this is a power chip test, positive. So painful in there. In this guy, we do the LCL reconstruction with palmolic longer stuff with the ipsic lateral size of palmolic longus. We do the two hole in the ulna and two channel in the humerus. And the fixation, we use a docking technique. And you can see that the ligament reconstruction is stay outside the joint. This is the result. Range of motion full and get rid of the pivot chip, and his elbow is no pain. Another case is have a Californian guy. He is martial guard. He have an injury between the fighting. He have a was arm bar and have an elbow dislocation. We have evidence that he has medial instability and lateral instability in the same elbow. So in this situation, they have a two global instability of the elbow. We do the box loop reconstruction in there. Many cases that have a medial and lateral instability, such as like a chronic dislocation of the elbow and have some subsequent of the medial and lateral instability. We also do the box loop reconstruction too. For the treatment of tardive posterolateral instability, you have a two tissue in there. You need to correct alignment. I use the pentalateral osteotomy and also the reconstruction of the lateral collateral ligament. This is the results. For the treatment of automatic PLI, such as like a chronic repetitive, prolonged tennis elbow, or maybe steroid-induced tendinopathy. We survey and have a series of the case of the 6 cases of the LCL reconstruction in automatic PLI and published in 2018. It showed that they have all improved in quick dash score, major elbow score, and hip strength. The video that showed that have the posterolateral downward test positive. How about the low or minimal invasive surgery? If we can do everything in one setting through the arthroscope, it should be nice and cool operation, right? And maybe we not need to take the glove, and maybe it quite minimize soft tissue injury in there along the minimal invasive concept. Arthroscopic LCL reconstruction from the knowledge that common spot for the LCL insufficiency is the humeral size. Most of the technique rely on implication or pigation of the tissue, make it tightening in there. You try to tighten the LCL, especially the radial part of the lateral collateral ligament, or maybe you can tightening the lateral collateral ligament. I use these two papers have an effect on me. I modify the technique from Felix Saward that have the present in the posterolateral rotatory instability by arthroscopic treatment. Here is a video clip. First of all, we divide the pica and or the tennis elbow or whatever the cause that can cause a chronic elbow pain in there. And prepare the bed of the implant that we can choose. This is a first video clip. So in that time we use the PES-FT, but you can choose another one, such as like a why not FEC 1.8 is okay. It also can use too, but it uses a two-tail double load in there, and the tissue is grabbed to the percutaneous tissue and use a lasso pass to the soft tissue, such as evident that radial collateral ligament, and tie the knot over the tissue, so make the tissue of the LCL tightening in there along the diagram that we showed. This example, like a nurse, 42 years old, prolonged lateral elbow pain, and treated with a tennis elbow by the 4 or 5 times steroid injection, and all of them failed. And the character of the pain changed from just related lateral elbow pain turned to be pain related with the push-up or chair-rise activity. She presented with the pivot chip apprehension positive and also have a push-up positive too. After the operation, she can come back and come to work, go back to work, and right now push-up is negative. And this is posterolateral downward test negative, and also have a pivot chip apprehension negative too. We can collect 14 patients on there, compare between arthroscope and 6 for the open reconstruction. The age is not different. Duration is 6 to 120 months. Zero injection is like a 3.7 times. Mean quick dash score, mean major elbow pain score index, and also upper performance index and visual analog score. All of them were improved in both. And both of arthroscope and open surgery, they didn't differentiate significantly. So in the case that the quality of soft tissue are concerned so much, such as they have like a laxity positive, such as a whole posterolateral downward test more than grade 2. I classify like a slip is grade 1. If the translation over the edge of the little head, I characterize that is grade 2. For the grade 3, it's like the condyle can jump over the edge of the little head, or maybe come from the post-traumatic. The concept, I observed that annular ligament have insertion quite near the spinator case. The dual reconstruction of LCL that presented by Min Jong Park from South Korea, they present that use the ligament wrap around the annular ligament and not do anything on the ulna, and can make a stable lateral instability in there. So it means that maybe they redirect and tie the lateral radial corner collateral ligament to be useful for replace the LUCL. Another guy from foot ankle surgery, they present the arthroscope modified Boston technique. They use the retinaculum to wrap around the LCL, lateral collateral ligament. Okay, why elbow cannot you do like that too? If the retinaculum turn to be ankylosing, what it be happen? This is another ankle that I do. It makes sense. It's quite stable too. So we start with the male 40 years old, Sawyer. Chief complaint, they have a pain and instability and can practice his career. He have a history of elbow dislocation before. You can see that they have evidence of an elbow injury, cartilage lesion, loose body, and many things inside. And this is from the volar compartment arthroscope. You can see that the little head can translate in the back to the back. And this is a posterior view from the arthroscope. It's type 2 side positive, ulnohumeral gap opening quite wide. So we choose to grab some part of the annular ligament. You can see the little head and some part of the annular ligament that cross to the back. One tail in each suture stay in articular size. Another tail is passed under soft tissue. So both of them join together at the exit portal in posterolateral portal, as we shown in this video clip. And later on, both limbs join together to the pop lock, and we use a pop lock pass into the lateral facet of the lateral condyle, and then we can make the collateral ligament tightening. This is another view, another case. We do the same thing in there. After debridement and get rid and prepare the bed of the collateral ligament. I pass the lossel and pass the suture. In this case, we have a true suture inside. In each limb of the suture stay in the articular size, and one limb stay in the subcutaneous tissue over the ankylosing. After that, we apply brace for 6 weeks, protect and limit extension 30 degrees, and sequence release to a full re-extension in there, about 6 weeks. This is the result. I think we can push up quite clearly, very nice and fully there. Thank you.